Welcome everyone in this beautiful afternoon. I would like to present my 3 months progress about my research work on the diagnostic and therapeutic options in sepsis and trauma-associated coagulopathy. My name is Tímea Mátyási-Dombi. I am a PhD student and a specialist in anesthesia and intensive care, currently working in Hungary Trauma Center, Budapest. I want to improve individualized hemostasis management in critically ill patients, and therefore I would like to generate high-quality data to develop evidence-based hemostasis protocols for better patient care. To achieve this, I have 2 ongoing projects. Both of them have started this fall and use the method of meta-analysis. My first project is about the efficacy and safety profile of thrombomodulin in sepsis-associated coagulopathy. Sepsis-induced coagulopathy is a serious complication, and in up to every 2 cases lead to coagulopathy with a mortality exceeding 30%. The dysregulated immune response in sepsis lead to the disbalance of hemostasis, and the exhausted anticoagulant mechanisms and hypercoagulopathy lead to organ failure and after death. This approach gives the idea that anticoagulant agent might be good, and one of them is thrombomodulin, which also has anti-inflammatory and anti-fibrinolytic activity. That's why it could be beneficial. The problem is that the current guidelines on the use of thrombomodulin are controversial, while the Japanese guideline weekly recommends in the therapy. The international one does not state at all. There are different target cohorts and diagnostic criteria in the RCTs, and that's why there is not enough evidence. A few recent studies show that this kind of therapy is effective for patients with septic coagulopathy and high disease severity. So our aim is to investigate whether thrombomodulin has any clinical benefit. It leads us to our clinical question: does thrombomodulin improve the survival rate of patients with sepsis-associated coagulopathy? We would like to use PICO framework, different subgroup of patients, and we would like to compare thrombomodulin therapy versus placebo, and we would like to investigate mortality, resolution, coagulopathy, multi-organ failure, and bleeding complication. We hypothesize that in any of the patient subgroups, thrombomodulin will improve survival, and this even may lead to even better improved clinical outcomes. There are previous meta-analyses about this topic, but they show that the bleeding risk is low, but in the overall septic population, thrombomodulin did not significantly reduce the mortality. However, the heterogeneity in the severity of coagulopathy, the disease severity, and origin of infection limited these results, and that's why we would like to investigate it in this meta-analysis. We have done a systematic search with this search key. We have more than 2,000 articles. After duplicate removal and title abstract selection, we are in the full text selection phase. and we are continuing our project. My second project is about the efficacy and safety of early fibrinogen supplementation in patients with severe trauma. Hemorrhage accounts for 30% of all trauma deaths, and this can even be exacerbated by trauma-induced coagulopathy in 1/3 of the cases. Both the consumption of fibrinogen and increased fibrinolysis lead to the rapid loss of fibrinogen. And this hypofibrinogenemia leads to, here again, organ dysfunctions and an independent predictor of death. The 2023 trauma and major hemorrhage guideline suggests that fibrinogen levels should be maintained about 1.5 gram per liter in patients with severe trauma. It can be achieved either by cryoprecipitate or fibrinogen concentrate. Fibrinogen concentrate is widely used in traumatic hemorrhagic shock, despite weak evidence, because it can be administered more easily to the patient. The missing link is that we don't know the exact timing of this therapy. In the 21st century, we have the opportunity to give these patients fibrinogen even in the trauma field or in the ambulance. And that's why we would like to investigate the potential benefit of early administration of fibrinogen in these patients. Our clinical question is, does early administration of fibrinogen improve survival in severe trauma patients? We use again the PICO framework with patients with severe trauma, and we are comparing early fibrinogen supplementation versus placebo, and we would like to investigate early 24-hour mortality and different other outcomes like bleeding risk, transfusion requirements, length of hospital stay, and thromboembolic event. We hypothesize that early supplementation of fibrinogen in trauma-induced coagulopathy can improve survival, and this may also lead to improved clinical outcomes of these severe trauma patients. I want to continue with my two projects and finish the first one by December 2024. And I would like to finish my presentation with the words of our famous painter Tivada Csontváry-Koszka. Every person needs a broader perspective to see more and to be aware of the divine nature. In a broader perspective, we find a new perspective. In a new perspective, we find a new life. Thank you for your attention.
I have a question regarding your first project. So as far as I know, DIC has different stages. Do you think thrombomodulin can be effective in all stages, or is it better if we give it earlier? That is my question.
Yeah, actually that's one point of this investigation, to find the exact subgroup of population. That's why we want to examine the severity of coagulopathy, because we think in the early phase of this coagulopathy, the thrombomodulin is effective, but not before and not after it. Thank you for your question.
Okay, so as early as that's the best if you give it earlier?
No, because if there is not coagulopathy in the patient, it won't be effective either. So we have to find the exact subgroup of population by the severity of coagulopathy.
My question is the pre-hospital administration of fibrinogen is available in Hungary, or where is it available?
Yes, it is available, and we have information that, and actually I see in everyday work that, for example, the patients who are transported by helicopter, they can even get fibrinogen in the field of the trauma. Yes, so
and they decided according to the bleeding severity and hemodynamic stability, because they don't have lab values at that time point.
Yeah, the severity, we have to, I have a slide about that. We use the injury severity score to define the exact patient population for who is suitable for fibrinogen, because if it's just a minor trauma, it won't cause any good, just harm. For example, increase the thromboembolic events. But if it is a severe trauma, and I mean by injury severity score 16 or more, it can be, it should be used.
Hi. So this thrombomodulin therapy, there must be a reason why the international guideline doesn't mention it at all. What are the potential harms that it can cause?
It can increase bleeding risk in some patients if it is not given in the right population. This is the main side effect of it.